Everybody to this webinar on the ethics of health systems research. My name is Bridget Pratt and I'm a postdoc at the School of Public Health at Johns Hopkins. And I'm also the coordinator of the Health Systems Global Thematic Working Group on the ethics of health systems research. So this webinar is part of a series being done by Health Systems Global, and this is the first webinar that our thematic working group is hosting. So thank you for joining us today. And now I'm just going to turn over to Joe Ali at the Berman Institute of Bioethics.
Thanks very much, Bridget. So welcome everyone. As you may note, we are recording the webinar so we can post it afterwards within our various networks and share it with colleagues who can't join today. It looks like we have a good crowd today. About 38 have registered at this point, have joined the webinar from, I'm sure, various countries around the world. So good morning, good afternoon, good evening, wherever you are. I am with the Johns Hopkins Berman Institute of Bioethics, representing the Fogarty African Bioethics Training Program. I'm pleased to welcome you to this webinar. If you perhaps can't hear me, then as folks will note in the chat box, there is an opportunity to test your audio underneath the meeting tab, and I encourage everyone to do that if you have any difficulty at any point with the audio. Otherwise, most of the chat will occur through the chat box, as if you will be following questions and comments throughout the presentation and bringing them up for discussion later on when we get to the discussion component of the webinar. There will be 3 poll questions throughout the webinar, one at the beginning, one in the middle, and one at the end. And those poll questions will be revealed in the upper right-hand corner box. So we'll bring that to your attention when it's time to answer polls, and it should be a fun little addition to the webinar. We will do, as I said, mostly text chat through the text box. On occasion, if you feel like you have a strong opinion on something and you would like to try to speak and use your microphone, please raise your hand. And there should be a little man or woman raising her hand at the top of the screen. You can click on that to raise your hand, and that will allow us to enable your microphone. We won't do that very frequently because it can overwhelm the technology and bandwidth for some participants, but we may do that. If you have any IT or technical questions, please direct those to me. My name is Joseph Ali, or direct them to Christina Halez, H-A-L-L-E-Z. You can send us a private chat, and we will try to respond to your questions through the private chat. So with that, I think I'll go ahead and introduce my colleague and friend, Dr. Adnan Haider, who is a professor in the Department of International Health at Johns Hopkins Bloomberg School of Public Health. He is the director of the Health Systems Program within the School of Public Health, and also the director of the International Injury Research Unit. With the Berman Institute of Bioethics, he's also associate director for global programs, where he also directs the Johns Hopkins Fogarty African Bioethics Training Program, which focuses on capacity development for institutions and programs in research ethics in Africa. He has been exploring this topic of ethics in health systems research in low middle-income countries for some time now, and has been so kind to agree to join us today and share his thoughts on the topic. So with that, Adnan, I'll hand it over to you and mute my microphone.
So hello everyone. I hope, thanks very much Bridget and Joe for introducing the webinar, and Joe for that kind introduction. So I hope everyone can hear me. If, as Joe mentioned, you cannot hear me or you're having any technical issues, please send a private chat to Joe Ali or Christina Halez. Both of them are providing support, and at the same time, together with Bridget, they're also going to be monitoring if you have comments or questions to talk about, making sure that I don't miss out on important observations. So I'm really delighted to have the opportunity to talk about something that I'm quite passionate about these days, which is exploring the ethics of health systems research. And today's seminar, I'd like to acknowledge right from the beginning, is a team effort. We have colleagues participating and helping from the School of Public Health here at Johns Hopkins, from the Berman Institute of Bioethics, from the Fogarty Africa Bioethics Training Program, both faculty, trainees, alumni, Very importantly, this is one of the seminars through the Health Systems Global Organization, particularly the thematic working group on ethics of health systems research, and also my colleagues in the Future Health Systems Consortium have tremendous support and help. And all of us, together with many of our other training programs, our doctoral programs, our Fogarty programs in Uganda, Pakistan, and other places, I want to have acknowledged many people who encouraged this particular seminar, and I'm delighted to see that over 50 of you have joined us today despite the time differences. I also recognize that for many of you this is probably evening, late evening, and in some cases might even be late night. So thank you again for joining me in this conversation. And it's already sent out, so you will note that I hope over the next 40 minutes or so to present to you a little bit of my thoughts around ethics of health systems research, and what I'd like to do in a couple of minutes what the challenge is in this particular area, and then go through a list of that. These list of issues are neither complete nor exhaustive. They are a list for us to start a discussion. Today's webinar is not the end product of 10 years of work, rather it is actually the beginning of initial explorations that we've been doing for the past 2 years or so. And then I'd very much hope to leave a good 15 or more minutes for us to have a dialogue, a discussion. My colleagues will be, as I mentioned, noting down your comments, and I'd really like to engage all of you today. And of course, if we don't have the opportunity to engage today, there will be many other opportunities, and I have towards the end of my talk, I want to highlight some opportunities for engagement and discussions coming up in the next 6 months or so. Now, with that sort of outline, I hope that gives you an idea of what we're going to talk about. I want to first start, and I hope you're all able to see the slide set. I want to start by first trying this poll. And I'd like to actually ask you if you agree. Right at the beginning of this webinar, some of you may have already thought about this, some of you may not have even thought about this particular issue, but I'd like you to respond to the webinar at the top of your screen there. Do you agree that health systems research actually has specific issues which are specific and distinct from other types of issues? So take a minute, go to that poll up front and give your vote. You can agree with this statement, you can say no, I disagree, there are no specific issues, you can say yes, I agree, there are specific as well as substantively different issues. But let's see all of you responding. I'd like to get a sense of what your experiences are, what your initial thoughts are, and you will be able to see the results of this poll as live. You can already see that we have lots of colleagues, nearly 40 people have already responded there. I'm so happy that everyone is participating here, and you can see that we've got majority of the people either highly or somewhat agreeing. It looks like a very dynamic poll. Thanks very much, Joe, for moving ahead. If you haven't voted, I'll give you a couple of seconds right now to do that. It looks like we've already got something like 46, 50, 47 people have already voted. So thank you very much. It's really interesting for me to see that many of you have similar feelings to our group here, that yes, there appear to be some very interesting issues that arise in the conduct of health systems research, which in fact might be different, might be quite distinct from other types of research. And when I say other types of research, it might be research which is clinical research, research which is more traditional, epidemiological research, and so on, or biomedical research. And I think that's something that we will keep in mind. So let's keep this window in our minds. Let's look at the distribution there. And I'm glad that some of you are actually unsure, because that's exactly when people are unsure about something, that some of the best thinking is done on these types of topics. So thank you very much again for participating. So let's begin this dialogue by first, today's session is not about health systems research per se, but I wanted to just make sure, literally for 1 minute, that we all understand that when I talk about health systems research, I'm talking about research which is of a broad dimension. It's research that is related to the production of knowledge about how societies organize themselves in order to achieve their health goals, how different actors, policy actors, implementation actors interact with each other and ensure good health policies. And very importantly, much of this health systems research, particularly in the contemporary time period, is being done around efforts to strengthen health systems around the world or support and understand health systems around the world. I'm sharing some formal definitions. I will tell you that there are multiple definitions out there. However, I've posed two which we frequently use, and of course, the Alliance for Health Policy and Systems Research, another great partner in our dialogue, is very supportive of our deliberations as well, has contributed to this thinking. I think it's extremely important for us today, maybe not necessarily to delve deeply into these definitional issues as much as talk about the general types of research that we do, and I have some examples in my slides later on so we can discuss specifically how this might apply to some of the ethics issues that we are in fact going to talk about. So let me paraphrase the challenge. The challenge that we have here is that we're going to discuss, as I said, for the next 35 minutes or so, a lot about the ethics issues in health systems research. But just for a moment, what I'd really like to do is to assume that we all accept that health systems research in fact is different and distinct from other types of research, such as clinical research. With that acceptance, then comes the premise that, yes, if it is in fact different in some way, then ought it to be the case that we should hold it to the same ethical standard as other types of research, such as clinical research. In other words, if something is truly distinct, then why should similar criteria be applied to it from an ethical viewpoint if we feel that it is substantively distinct from other more, let me call them for the sake of discussion, more traditional forms of research? And this is the premise that we are going to start with. And as I mentioned again, this is initiating a dialogue, and I'd actually welcome disagreements to this premise both now and later on in our future engagement. So with that challenge, I think comes a tremendous responsibility for us. Because in fact, what happens is that to respond to this, we have to understand what are these ethics issues that arise in health systems research. Because clearly, some of these issues might be very similar to other types of research. And in that case, they might be very amenable to general ethical analysis that we do for clinical research, for epidemiological research, and for other types of research. However, the case that we are making is that there are particular and very specific types of ethics issues that might arise in health systems research, which therefore will require specific ethical analysis. And this ethical analysis might be different from the one that we apply in other types of research. Now, I will also indicate that it is also true that while I'm generally talking about health research, it is important that we also acknowledge that I am also cognizant of the fact that there are similarities and differences with other areas of research. This might be social science research, it might be development research, it might be even environmental research or other sectors. And so I think when I talk about the unique aspect of health systems research, I'm referring to the uniqueness vis-a-vis health research. And I think that is extremely important for me to recognize, because the more we talk with colleagues in other sectors and in other fields, some of them actually have quite a bit of experience dealing with some of these issues. And I'd love for those of you who have experience in those fields to bring that to our discussion, to bring that on the chat board today, but also in the future. And I'd love to see an intersectoral dialogue, particularly a multidisciplinary dialogue on these issues. So I hope that I've covered my bases with presenting the general theme of the challenge. And what I'd like to do very much now is to sort of dig deep into the trenches and really talk about what are some of these interesting ethics issues. So let's begin our journey, and please remember my caveat that these are a list of issues that I've selected for discussion. These are neither exhaustive nor are they mutually exclusive to HSR, but these are some of the issues that I hope to demonstrate some of these differences. So the first issue that I'd like to talk about is really around what is the intervention in health systems research. And it is important to understand that in health systems research, there are a variety of measures and methods that actually might be the intervention. In other words, it could be a message, it could be an incentive, it could be a measurement tool, it could be a financial package, it could be a delivery system. And the diversity is large compared to, again, and I'm going to use in my discussion for the sake of ease, rather than use multiple comparators, I'll use clinical research as a comparator for this particular discussion. Again, feel free to bring in other comparators. So compared to clinical research, for example, the intensity of these interventions, their invasiveness, their duration is extremely different. And I think the nature of the intervention has to be demonstrated very carefully. In fact, as many of you know, the conduct of research itself is often considered an intervention. So it's very important for me to also preface that irrespective of what types of research we talk about, the fact that we are intervening in a community, that we are present in a community, that external agents are present in a community is in fact an intervention in and of itself. Again, I may not have enough time to talk about that today, but I would love to bring that into the discourse. Now, it's also true that, like clinical research, sometimes we have untested biomedical interventions as part of HSR, and when that happens, HSR becomes very similar to clinical research. But with my focus on low and middle income countries, that is something that more contemporary health systems research is not necessarily doing a lot because other colleagues are already involved in that type of biomedical or clinical research. So we have new delivery or dissemination methods. We might have mechanisms of creating demand. We might have a new package of interventions. In other words, we take two existing interventions and they have never been put together, and we consider that to be a new package. And very importantly, my colleagues who work on health economics, on costing, on cost effectiveness analysis, or those who work on policy impact are doing lots of health systems research, looking at the impact and effect of these on outcomes that are important beyond health outcomes, on economic outcomes, on social outcomes. And of course, there are ethical concerns beyond those of the individual interventions that arise in these contexts. And so, I think it's important to recognize that when we look at these interventions, everything from messaging to health insurance mechanism, we must have important criteria. And these criteria have an important bearing on the ethics side. Obviously, we always are concerned about our science. What is the scientific background of proposing such an intervention? And this is critical for any type of research, but also must carry through in health systems research. In other words, we are not giving health systems research an exception to have poor science just because it doesn't have biomedical interventions. Similarly, are there other relevant experience related to that delivery mechanism or communication strategy or policy strategy? What is the history of that? And there might be interesting safety concerns, not only just ethics concerns that might be relevant to our discussion. And then, of course, important issues around future availability, future benefits. So just because you're talking about a community health worker strategy doesn't mean that you don't talk about the benefits or the future availability of that delivery mechanism once your program is done, once scaling up is in place. I think it's important for us also to hold health systems research to these types of questions, which of course have bearing on ethics issues, as many of you will obviously recognize here. These are questions that we ask ourselves about any type of intervention, and I am proposing that these questions are equally relevant in our case. It's just that the nature of the intervention is not a medicine, it may not be a drug, but rather the nature of the intervention might differ. I have colleagues that also talk about the fact, and particularly a number of colleagues who've corresponded with me on email have talked a little bit about non-intervention health systems research. And when I say non-intervention health systems research, they say, well, you should not pronounce HSR only about intervention, and I completely agree with that. I understand the process. In many of our health systems research are trying to understand why things happen. But as some of you have already acknowledged, I see on the chat board, that in fact, research itself is an intervention. So even though we are in there understanding importance, social processes, as I see some of you are now putting up on the chat board, understanding phenomena, in fact, that might be an intervention on of itself. So I am indeed coloring today's session around intervention simply to make a few points, but I want to acknowledge and accept that there are critical forms of HSR that are non-interventional, so to speak, in the classic sense, but that we ought to think about through a similar ethical type of lens, and I'd be happy to come back to this point. So the first issue that I've raised is what is the nature of the intervention, and there are specific ethics issues around that particular issue. Let's go to the second issue I want to throw out there, which is who is the research subject? Now, I want to comment here that in fact in many forms of health systems research, we actually have research subjects that may not even be considered humans. And that, of course, is interesting for all of us. So, for example, we might have hospitals or schools or educational institutions or cars or motorcycles being the subject of HSR. In my other life, I do a lot of trauma and injury research, and very often our unit of allocation is, in fact, motorcycles and cars. But many of you, of course, are involved in human subjects research. And in human subjects research, when we are dealing with individuals, then of course many issues that are similar to, for example, clinical research come to bear about doing research with individual human beings. On the other hand, many forms of health systems research are about populations and about groups of people. And in fact, not only groups of people, but about the systems in which those groups of people are interacting, about the health systems, about the social systems. And these raise additional ethics concern which may not arise in traditional or classic clinical trials. So here, in fact, I want to spend just a minute on groups as research subjects. And many of my colleagues historically have talked about the moral status of communities, the moral status of groups, who represents and speaks for these groups, what are the sources of legitimacy and authority. And many of you, I'm sure, have worked on these issues, and I see from the names here, many of you have published wonderful papers about looking at power dynamics, looking about legitimacy around these issues. And it's very important that we look at that when we do health systems research. In fact, colleagues like Wire have proposed principles for respective communities where in fact the communities themselves can be the source of values on how to deal with them. And in fact, communities have existing social structures. They take decisions for their communities. They have criteria on which they take their decisions. And it's very important for us in this ethics discourse to bring those voices, to bring those ideas to the table. In other words, I'm also very conscious, since I work extensively in low and middle income countries, that what has often been termed, quote unquote, the Western perspective of ethics is not necessarily imposed on cultures and communities that have their own perspectives on this. I'm also, however, a firm believer on interaction and collaboration, and saying that we are better because we talk to each other, because these cultural concepts come together. So I think it is important that we begin to bring some of these principles to the fore. And therefore, what I'm proposing here, that when we talk about research subjects in health systems research, we ought to be really careful and identify who is the subject. And these subjects then need to be the source of further ethical analysis. And a classic ethical analysis just based on individuals may not be enough. And in fact, this is an issue that I will raise in a couple of minutes with some of the other points that I'm just about to make separately. But I would really like to talk about this, and I see some of you are commenting about the importance of understanding communities and the inequalities and the representation of minorities, extremely important points, and that is exactly why when ethics committees are discussing health systems research, they need to be cognizant of the implications and the complexity of the research subject that I'm trying to raise. So do is then move on to a very related topic, which is about the unit of intervention versus the unit of data collection. And here what I'm trying to identify maybe is better explained using examples. One is that, for example, in a situation where we are doing health systems research, let's say around dental education, we might select schools. And in the schools, we might train teachers to provide, for example, dental education to children. But the data we collect in terms of outcomes are actually collected from the children. So you see, we have schools, teachers, and children in this particular example. Or if we are doing health systems research in the case of hospitals, we might select hospitals and intensive care units. We might train healthcare providers on quality assurance activities. But then, while that is the intervention, the data on outcomes is collected from patients. Once again, the unit of intervention delivery is not the same as the unit from which the outcome data is collected. And this is very interestingly different from the classic traditional model of clinical research, where you give the same individual the drug, the medicine, and you collect data from the same individual in terms of the outcome or the impact. And I want to make sure that this particular issue, therefore, is also understood as potentially being different from other types of research. And this is because what we are saying is that the units of allocation and the units of data collection are different. In fact, what is even more complex in health systems research is that there are multiple research subjects. You can have a primary research subject. So for example, in this case, it might be that you have communities who are research subjects, but then you actually implement a particular intervention that is implemented through community health workers, and then you collect data from households, but you also interact with individuals. So you have actually 4 different types of research subjects, and all the way from, people have called them primary, secondary, and tertiary research subjects. And this, of course, raises a whole host of other related issues, which I will come to in a minute. Things like whose consent, who's consenting, whose risks, and whose benefits are you actually going to talk about. And again, in a complex health systems research, all of the research subjects ought to be discussed from an ethical perspective. Each one of their risks, each one of their benefits ought to be understood if they are actually directly or indirectly participating in a health systems research project. So this point is really about the diversity of research subjects which comes to the fore in health systems research. The next point that I'd like to do, and please recognize that I'm sort of, obviously there's tons of things to discuss in each one of these. I completely appreciate, and I'm really hoping that we can talk a lot more about some of these, and I'm going to take a pause in about 2 or 3 minutes to ask you whether any of these are making sense to you or not. But let me go to the related point that I just raised about multiple research subjects, because the 4th point that I'd really like to emphasize is about informed consent. And many of you, I know, have worked on this issue and published on this issue. When we take informed consent or interact with individuals in HSR, we will take, obviously, informed consent from individuals. However, we've just discussed that in HSR, many times, we're interacting with groups, and so then, in that case, we obviously will look at group intervention. And in this case, of course, informed consent becomes more interesting if you are rolling out, for example, something like bed nets. You can take individual household consent before you leave the bed net. On the other hand, if you have a social marketing campaign, for example, on a radio, any individual who doesn't want to participate can switch off the radio. If you're distributing vouchers for transport in a conditional cash transfer type of situation, anybody who feels voluntary can refuse to take a voucher, and so on. In other words, there are different types and forms of voluntary refusal of informed consent that will occur. And I think it's very important that these issues obviously are issues that, in fact, of some of the issues that I'm raising are not necessarily specific to health systems research, particularly in low and middle income countries, but I think are important for us to discuss. We are coming to it from the perspective of looking at a holistic form of health systems research, and I think it's very important for us to raise these issues. Raise issues around who's consenting, what communities are they representing? What is the legitimacy for the consent itself? And very importantly, what I have called the coverage of consent. In other words, what is the diversity of population groups that consent is actually covering? It is possible that if we've identified, for example, 15 different subgroups in a community, one type of group consent might cover 10 of them, but it ignores 5 of them. And I think that's important for us to look at, think about, and I think what I'm proposing here really is a mechanism where we make the consideration of informed consent by different partners in the community a necessary part of the ethical dialogue. And to ensure that while we may have community consent or group consent, is that truly sufficient? Particularly in communities which have complex histories, where there might be notions of mistrust or in the population, where there might be huge power differentials, where there might be staggering inequities, and so on. So I think it's important that obviously there are things done for us, but the challenge to us in health systems research are clearly that is this really sufficient? And I already see colleagues commenting about notions of how do you know that this consent is really valid and true, and what is covered and what is overlooked in these types of consents are also extremely important. So I'm very happy that I think this is an area where we really need to do more work. So let me pause for a minute here. I've talked to you a little bit about the nature of the interventions in HSR. I've talked to you a little bit about the research subject, and I've also talked to you about how the units of intervention and data collection can be different and the implications for that for informed consent. I've been talking quite a bit. I'm going to pause here and try another poll. I would like to know, of these 4 issues, have you come across these issues in your own research studies, in your own health systems research studies, with a focus on low middle income countries? If you could take a few seconds to respond to a poll, I just want to get a sense if these issues are foreign to you, if these issues are unknown, if these issues are very, very common. Am I really talking to a group of colleagues around the world who really thought about this or not? Because I want to value each one of your contributions as well. So if you can take a minute, and I see many of you are already doing that. Have you come across this very, very frequently, or is this something you've come across occasionally? Or in a few cases, it might be that you've never come across this. And I'd be happy to see what the distribution is in this poll. It also gives me a minute, if you wouldn't mind, to take a sip of water here, and then I'll be back with you in a second. It's really wonderful to see so many colleagues join this group. And Joe, I think we're getting a wonderful response. It looks like a good 60% of you have occasionally heard, and 30% of you are indicating that you've frequently heard at least the 4 issues that I've talked about. Thank you very much for this. I'm so reassured, I'm so relieved that so many of us in the field have really come across these issues. It's great, and I really look forward to your comments. I want to emphasize that, by the way, I have slides. I don't have to finish all of them, but I can easily run through some. I want to make sure that we have some time towards the end for interaction. So I promise you that I will not interfere with our 15-minute discussion time. Let me raise the next issue, which often comes from a methodological point. Many of you must have discussed this in terms of what is the comparator in health systems research. Then what is the nature of the control group? So for example, if we are trying a new delivery methodology, it might be that our comparison group might be a group receiving the old delivery method. Or if we are trying a new package of intervention, for example, we've taken intervention A and B that existed separately, we've now put them together into a package of A and B, maybe the comparator group receives A alone or B alone. In other words, many health systems research study will use comparators either of convenience or comparators that are possible in a real world setting. And these might be similar districts, it might be similar cities, similar urban areas, or as I've just mentioned, a few examples from the perspective of looking at what is already going on. And so this raises very important questions vis-a-vis both in terms of the nature of the comparator or the control group, and then what does the comparator receive. And again, the issue here is there is no usual, there is no norm in health systems research, and there's tremendous wide variation from groups that may be receiving so-called nothing, in other words, a true control group, to groups that may be receiving exactly the same things but only a few days, weeks, or months later. In other words, where studies build in time delays into that type of mechanism, and those of you familiar with study designs like the step wedge study design understand that the nature of the comparator is only a delay in time for receiving the intervention. And of course, this also then begs for many of us the discussions which have been happening for the past decade or so around the standard of care. If in fact we transpose that phrase from standard of care to standard of delivery, or standard of policy, or standard of health insurance, or standard of safety nets, then you can see the analogy I'm trying to make in terms of what does the comparator group receive. What form of delivery system, what form of package will they receive? What are the benefits to those communities eventually from this research? Because one of the principles that we are always espousing is that communities involved in research ought to be, in some shape or form, better off at the end of that research than when they started research. And this is a goal that many of us try and think about prior to initiating our studies, in particular our health systems research studies. So the nature of the comparison group is something that I'd like to raise with many of you. I think the next issue that immediately comes to bear, of course, from that is the nature of the risks involved. What is, in traditional clinical research, we used to talk about therapeutic and non-therapeutic research, what is going to help the individual versus that which doesn't. And that concept sometimes doesn't translate, because imagine if you're doing a social marketing campaign which is anti-smoking, or you're providing incentives for some sort of health behavior. And what is it? But I think the fundamental, again, goal here, as many of my colleagues in health systems research have been writing about, is what is the most optimal scientific design that can answer your question with minimal risk? And this is important, with minimal risk. And in fact, since many of us work in or with the low and middle income country populations, we in fact are always working with vulnerable populations. And that in fact is our primary motivation. So to say that we ought not to engage with vulnerable populations is actually also a disservice. So then the question becomes, how do you manage these risks? And how will you minimize these risks in a way that is acceptable? And there, of course, opens up another area of great ethical discourse, which is what are the types of risks? These risks might be real risks to individuals or groups. They might be perceived risks. They might be social risks. And then, of course, as I've just indicated earlier, risks to whom? These risks might be to the primary, secondary, or tertiary research participants. But don't forget, there might be risks to those who are intervening as well as to the system itself. And therefore, defining this concept of minimal risks for health systems research is very tough. And I know that my colleagues on IRBs, institutional review boards, and on research ethics committees have grappled with this considerably. And I think this is another area of important discussion around risks and benefits. And as some of you are indicating, that in fact when we do participatory research, when we do community-based research, in fact the boundaries of risks and benefit can indeed be blurred. I want to make sure that I now wind up in the next couple of minutes is to simply highlight a couple more issues. I won't have time to dig into them deeply, but simply to highlight the next issue about the special concern for vulnerability in research, that many of us do health systems research with the specific focus of helping, assisting, and I think therefore it is incumbent on us to discuss the ethical dialogue around the voices of these vulnerable, particularly those who have been labeled even the most vulnerable within the vulnerable category. For example, extremely poor women in the types of research that I do, for example, those who are physically disabled, for example, from injuries or trauma. These, in fact, are even extremely vulnerable groups. And how do we address this? What types of discussions do we need to have in our ethics committees? The next one is around benefits. What types of benefits are we going to talk about? I feel that current guidelines that are existing don't cover the range of benefits that are possible in health systems research, because we don't always talk about benefits to individuals. We are talking about not just healthcare or treatment. We're talking about capacity building and strengthening of health systems. And we're also talking about distributional issues and benefits. This is another area where, unfortunately, I don't have enough time, but I would like at some future point for some discussion. I have a table on the next slide just showing you how, in fact, support to health systems is hardly acknowledged across many ranges of guidelines, and I would like to propose that supporting and benefiting the health systems ought to be considered as a benefit in the long run. So let me acknowledge by saying that I haven't talked about many issues. I haven't talked about quality assurance activities, which many of my colleagues do in HSR. I haven't talked about public health surveillance. I haven't talked about long-term HSR. Many of you might be involved in demographic surveillance systems for decades. There's a huge area of work in gender in HSR. We haven't had the opportunity. And then I know some of you are talking and discussing issues around justice issues. And I think these are very, very important issues that I'd like to just throw out there. I'd love to see if some of you have comments around these issues. And let me wind up by saying that my basic fundamental premise for today is that I want to say that these issues have not been finalized. In fact, they need to be better understood. They need to be evaluated both conceptually, but also empirically. And very, very importantly, I think that we need to address these issues. It is time for the field of health systems research to really take ethics issues head on. And we are now very, very lucky because we have so many partners, all of you here who are present today, but all of you, those who expressed interest in this dialogue, partners who are from donor agencies, academics, community-based organizations, individual researchers. We need to initiate a global discourse in this, and I hope that with this webinar, we launch a renewed effort to talk about some of these issues. I want to let you know that today's webinar and today's discussion is not the only opportunity. I want to highlight that if you would like more information, please see, and many of these will be a notepad here in front of you. If you want to join the discourse, we have a lovely thematic working group called Ethics of Health Systems Research in Health Systems Global. Please join. We have lots of other resources, both at our institute here at Johns Hopkins and many of the NIH Fogarty supported programs, as well as in the Future Health Systems Consortium. I'd like to acknowledge these opportunities for these, and I hope many of these slides will be archived so you can take a look at that. I want to make a shout out for some of the events. Next month, we have a workshop at Brochure Foundation in Geneva. If you're interested, and many of those will be archived as well. If you can't make it, we want to make sure that that material is circulated. It's very exciting that on September 30th, we have in Cape Town, South Africa, a meeting of our thematic working group as part of Health Systems Global. I hope that many of you will be there. And then in Baltimore in December, we have the conference on promoting responsible research. As part of that, we have a special symposium here on international research ethics as part of the Primer conference. And again, so opportunities in Europe, opportunities in Africa, opportunities here in North America, lots of opportunities for everybody to be involved. Your voice can be heard. I encourage you to reach out to us to initiate the dialogue. I want to thank all of the people who helped me today, and I want to initiate, I would really like to initiate a dialogue now and see what types of comments we've had. So Joe, Bridget, and Christina, tell me what sort of important discussions we are having. I see lots of comments.
Yeah, thank you very much, Adnan. That was a wonderful presentation, and as you can see, it did stimulate a lot of discussion in the chat board. We've had a number of comments from participants, and I think maybe we'll sort of start with one of the earlier comments from Liz Hoffman, which was she asked whether one of the differences between the standard clinical research and HSR is that more often the subjects are health workers in HSR than patients. So I suppose the question is it easy for health workers to decline to be involved, and what does it mean if health workers are involved in HSR as opposed to patients? Does that raise any unique issues or questions?
So I think that's a great set of issues. I'm not going to pretend I know all the answers, but I think you're raising two domains of issues. The first domain of issue is that, in fact, you're re-emphasizing how the research subject in health systems research range all the way from providers to the communities to the community health workers themselves. I think the second issue you're raising is the voluntariness of different types of research subjects. And one of them that we are very concerned is obviously those of the implementers, the community health workers, for example. And I think that this is an issue that has been recently raised in some of our workshops as well. And I'm not sure we've thought about this intensively, and I'd like to hear responses from our colleagues here on the chat board as well, about those of you who might have thought about or interviewed community health workers. I know that one of my colleagues, Robert Sesagubu, a few years ago, as part of the Fogarty Africa program, actually did a wonderful piece of work exploring implementers' perspectives on research ethics and how they felt, both in terms of conducting that research project, but also their perspectives in being involved in it. And I suspect that their voluntariness, unfortunately, in many cases, might be somewhat limited. In other words, it is limited because they may not have the opportunity to say, no, I don't want to do this, or I don't want to participate, because in some way that's connected to their livelihood. And secondly, their ability to report violations or even small aberrations and deviations from the agreed research ethics plan may also be limited. In other words, you know, there might be changes that are happening post-approval to health systems research projects that these community health workers feel constrained because, again, of the power structure within the team, because the principal investigators may be external, because the principal investigators might be high-ups, and so on. And I think this raises a whole host of issues. I think we have not discussed this topic. I couldn't catch the name of which colleague raised this issue. I'd really like to initiate a set of dialogue around that. It would be really, really important.
Yeah, thanks. I think that's great. Liz Hoffman was the one who rose the question, and I think that it also relates to another question that Michael Clark raised a bit later on about perhaps ethical HSR is inclusive of community participants in the research team. So essentially saying that have we thought about in research integrating research participants, whether it be traditional sort of patients or community health workers and the like, into the actual research team itself, perhaps to help bridge that gap a little bit?
Yes, I think I really liked one of the comments that I saw in Fleeting, that HSR itself is political or something to that effect. I think we often forget, and I know colleagues have written on the political nature of research itself. And I remember nearly 20 plus years ago, as a young research student in South Asia, where there was a huge discourse on setting up surveillance sites. In those days, the unfortunate term of population laboratories used to be used, and this whole nature about who is observing whom and for whose benefit. And I think the discourse around the invasiveness of research needs to be emphasized within an HSR perspective, because what we are saying is in fact that we want system change. And system change is not about one process or about one group of people, but rather about a collective change that ought to be in the interest of the collective good. And I think that to me becomes a huge goal, a huge vision for HSR. Now, of course, I think it's not possible to have a vision that is then operationally applied to individual small research studies. So I think we have to be very careful in how we take these visions and these goals and apply them to our ethical analysis for individual research study. So I want to make that distinction, that I think there are many research studies that are aiming towards that vision, aiming towards that goal, aiming to help us understand the political economy of research. But each individual project might give us one part of the jigsaw puzzle, and I think it is also a disservice to stop research, to prevent research from happening just because it doesn't solve the entire puzzle. So I'm giving a complex answer because I think this is a complex issue and there are no simple observations on this.
Yeah, it certainly is. We had a few other questions.
Joe, Christina, other?
Can you hear me now over there?
Yes, just speak a little louder, Joe. I believe some comments were about you just getting a volume, and we'll do another 5 minutes and then we can start winding down. Joe, are you there? Okay, I'm not sure we can hear Joe, so that's okay. I've also just seen some additional comments, because I think one of the interesting comments is about health systems impact assessments. I think this is a very interesting suggestion about having a tool akin to or similar to what environmental impact assessments have done, and in other cases of technology, what health impact assessments have done. Could we do something similar in the field of health systems? And I think, Freddie, I think you're raising this issue. I think this is important for us to think deeply. I think at one level, I think it is possible to do some predictive assessment of how a particular research intervention, but more importantly, the intervention that we are trying to study, and what the implications and the pathways of change might be if those interventions are implemented. And I think it's very helpful to do that. I also think, in an interesting way, for people submitting IRB or ethics committee applications with a health systems research project, they may be asked to, just like we ask people to talk about their risks, maybe we ought to ask them about what are the impacts that you feel might occur on health systems as a result of this potential intervention or study. And I think that that might be one way to go. I'm a little bit wary of making it extremely deliberate or extremely tight-jacketed, because I think we aren't done with the thinking. We haven't completely figured out what would be included in this type of an assessment. What are the technical criteria? What are the ethics criteria? What are the political criteria by which such an impact assessment would be acceptable or not? But I think it's a great suggestion and would love to have some more discussion around this topic. So again, I don't know if Joe is back on, if I've missed.
Yeah, I'm back. Hopefully you can hear me now. Yeah, there was maybe just a couple of more comments here in the chat board. I see Sassy Molyneux who has joined us for this discussion, and she has a question, I suppose, or a point about perhaps there being sub-areas of health systems research ethics. So this field, I guess you would call it, has been introduced relatively recently, but we're already hearing calls for subfields given the diversity of research designs that may be implicated within health systems research ethics. And then Sassy also mentions then perhaps there may be some cross-cutting issues then across the field that are of interest, having to do with the relationship between actors and power relations and the like. Not sure if you have comments on that or not, Adnan.
Thank you very much, Sassy, and lovely to see you on the on the webinar. I think those are important issues. Let me make two observations, because obviously we need to think a lot more about this. My first observation is that yes, I think that there are sub-areas of health systems. For example, the workshop next month in brochure is going to focus on the methodological implications and the ethics around specific methods that we use in health systems research. I think another sub-area which is tremendously important is around consent. and looking at the diversity of issues around those types of areas. Another area which I know that colleagues like you and Asha and others are going to explore is the area, which I think is another sub-area. So I think you're absolutely right. We need, literally lots of people working in these sub-areas. On the other hand, my second observation is that it's taken us many years to try and build a cohesive community, which now under the at least the umbrella of the Alliance for Health Policy Systems Research or the Health Systems Global, and many of us in other communities are trying to say that health systems research is an area of work. It has its own approaches, its own methodologies. Now lots of interesting papers from colleagues, including from our program here, like David Peters and Sarah Bennett and others, arguing for this is a field. And so I would also voice that yes, while we want to look at these sub-areas, there are some generalities. Just like we talk about the specifics of HSR and the learning that can be done, but also the generalizations that can be learned across contexts, across issues. And I would also urge us to think at both levels. What are the specifics, and then what can we learn across these types of issues? And I think both are needed, and I hope that colleagues like you and many others, all of the colleagues who've joined us today and others who might listen to this will participate. I'm really grateful for all of you to having joined us today. I really want to, since I see we have about 2 minutes left, wind down. But before you go, I'd like once more all of you to participate in a quick survey again at the end of this seminar. I'm asking you exactly the same question that I asked you when we started the webinar, which is, do you agree that HSR has ethics issues which are in some way, shape or form specific and distinct from other issues? I'd like to see what our distribution is at the end of this webinar. I'd really like to use that to launch more discussions around for our future. And so please take a second. Joe has put up the webinar over here, and I'd very much like you, before you leave, to give us a quick response. I already see that we've got now 70% saying highly agree. In the previous seminar, we had about 30 or 40%, if I recall. So it looks like the distribution, because now I presented to you nearly a dozen issues as opposed to the 4 or 5 issues that I presented earlier. So this is really wonderful. I'm really grateful for all of you for joining. I would like to once again acknowledge all of the partners who supported this, particularly my colleagues here at Johns Hopkins University, the Berman Institute of Bioethics, the Bloomberg School of Public Health, Department of International Health, the Health Systems Program, all of our colleagues at Health Systems Global and the Thematic Working Group, all of our Fogarty programs in bioethics, in injury and trauma, and of course Future Health Systems Consortium, and many of you who encouraged both us to do this thinking. I'm really looking forward to lots of more discussions, lots of more debates. Do not hesitate to disagree. It is only in disagreement that we find some of our most brilliant thoughts. So once again, thanks to all the technical, my colleagues Bridget, Christina, and Joe in particular. This seminar will be archived, so all of this will be available to colleagues who could not make it today. I welcome their contributions and hope to see many of you online, on Twitter, on Facebook, and so on. Thank you very much, and have a great afternoon, evening, or good night, wherever you are. Thank you, and bye-bye.